at a really interesting crossroads right now with the pandemic. And a lot of it's going to be the next phase of where we go with this is going to be so much based on the history of, a distant history, but also a history of how things have gone and how things go forward. And, how the public trusts us, but, also how we trust each other and how we trust the institutions that we work in. So my first disclosure, which Emily already talked about, I work for Gilead Sciences. As part of that, I am a stockholder in Gilead Sciences, but I will not discuss any medications in this presentation. So I think pretty much, this is a department that everybody is very well versed in the sociocultural determinants of health. Basically, it's just conditions and places where people live, learn, work, and play that are not really about their biology, but about their environment. Trust is an interesting word. I've talked about trust in previous grand rounds and many years ago, and sort of revisiting this in a new context. But trust is an assured reliance on the character, ability, strength, or truth of something or something. So there's many layers of this. Is that, do I trust you, individually? Do I trust the institution or system? And then there's situational trust. I may trust you for one thing, but I don't trust you for something else. So trust really occurs also in an ecosystem. We're the position in the middle of the ecosystem. We have all those people who depend on us, below us, mostly our patients, but also, you have to remember, our staff and our trainees, our students, our colleagues. Then there's the institutions we're part of, which we depend on them. We depend on them to be somebody that we trust, that we share their values, and they trust us. They need to trust us to do a good job and to carry out the mission. So I'm going to talk first about Philly. That's where I come from, and I have this idea of the trust thermometer. Philly is a city with incredible inequity. It's an incredible place to live. There's a 23-year gap in life expectancy between the poorest zip codes and the richest zip codes. I was an HIV doctor for 20 years. 2008 was a rough year. 2008, we had the highest rate of perinatal transmission in the country. We had 8 perinatal transmissions in Philadelphia. 6 of them came to us at St. Chris. 3 of them came in 1 week. System-wide in Philly, there was 50% of the people that were diagnosed with HIV had a concurrent diagnosis of AIDS at the same time, which is, it's just horrible. So, one of the things that happened in Philly is that all the providers, there's 5 medical schools in Philly, and everybody got together. All the HIV people got together and said, we can't let this continue. We're going to finish. We're going to make this better. So there was a system-wide effort to make it better. And then also, we at St. Chris, we said, we can't let this continue. We're not responsible for these perinatal transmissions, but we're going to do something about this. We're going to go work on the systems where this happened. And, when I left in 2015, we'd had several years with no perinatal transmissions. And, I was also very proud of the clinic that we had built around those principles, and that we had the highest rate of adolescent retention and undetectability of virus of all the Part D Ryan White programs in the country. So these things come by team effort, but these things also come by individual effort. So I'm going to do a series of what I call my homegrown heroes, homegrown solutions. So this is Ellen Tadaldi at Temple. She was a full professor. She'd done clinical trials. She's nationally known for women's health and HIV. And, we in Philly decided we were going to start testing in EDs, and, her ED was very focused on trauma, didn't want to do that. And so, she turned a broom closet into an HIV testing room that was down the hall. She put up a sign in the ED that said, free tokens for the subway, and, put little footprints on the hallway leading up to the broom closet, and started testing. And it was both the team effort, the system effort, but it was these kinds of individual efforts. So somebody who just stepped outside of their role and made things better. I'm going to introduce this and then come back to the story. So this was some of the work that I was doing with Focus over the last 5 years. Is one of the states that my team was assigned to was Kentucky, and we were in Louisville. Everybody told us in Louisville, you need to be in the eastern part of the state. So we looked at these maps. I love maps. You'll see that through the rest of the presentation. And we saw the rate of opioid overdoses in the eastern part of the state and said, well, if people are overdosing, they're probably also not using good harm reduction techniques around virus prevention. And at the same time, the CDC also got very interested in this area. So one of my team members and I and a uniformed CDC EIS officer, marched into a hospital in Eastern Kentucky and said the thing that I think everybody dreaded was that, we are from the government and big pharma and we are here to help you. And it was so compelling to be there. They weren't so compelled to have us in the beginning, but it was so compelling to be there. We suspected that there were very high rates of hepatitis C. Kentucky had some kind of quirky laws that only certain people could treat it, and so we had women that were diagnosed down there that had to go all the way up to Lexington, and were actually exchanging oral sex to get rides. Because of the system problem that, nobody down there, despite being very good doctors, nobody down there could treat them. The suicide rates in preteens were surging from watching their parents overdose. I had little kids on the jungle gym miming, putting a tourniquet on their arm and injecting themselves. I mean, it was just a really, really dire situation. And we really felt like we could make a difference, but knew that we had to build trust first. So how do you know where there's areas where there's problems? So CDC has this thing called the Social Vulnerability Index, which looks at a whole bunch of different factors of social determinants of health that look at potential negative effects on communities caused by external stresses. And with the idea that these stresses are going to make it so that there's a disaster, a disease outbreak, that things aren't going to go well. And except for the Northeast, which is a little complicated to explain why the Northeast isn't as dark as it is, as the other areas, you can pretty much superimpose any COVID map on the Social Vulnerability Index. And indeed, when you look deeper, this kind of pretty much pans out that looking at a good study done here out of University of Michigan shows looking at 4.3 million US cases and 147,000 deaths, found that for every 0.1 point in the SVI score that goes up, you get a 14.3 increase in incidence rate and a 13.7% increase in mortality rates. That's an excess of 87 cases and 3 deaths per 100,000 population just by having increased vulnerability in the area. The increased vulnerability isn't something innate to the population. The increased vulnerability is all caused by decisions that people have made and really system factors. Another study done out of Emory at Grady Health looked at employees who developed COVID and found that it was really much more related not to their job, but for their community contacts, and found an odds ratio of 1.9 for community contacts with someone known or suspected COVID positive, mostly based on their zip code. And, areas of high incidence, they divided it into areas of high incidence zip codes and low incidence and found an odds ratio of 1.5. So how's Minnesota doing with social vulnerability? Zooming in. So we'll look at 2 counties, Hennepin, Ramsey, where we are now, and Monolith County. And on the left is the social vulnerability on the right. And, it tracks pretty well. Minnesota has only one area in that dark blue, which is in the lower 4th percentile of social vulnerability. And, you also see your biggest circle there for COVID rates. So let's look a little bit more at Monolith County. So Monolith County is the only county in Minnesota. I am loving learning about Minnesota as, having newly moved here. So it's the only county in Minnesota that is entirely within an Indian reservation. It's 5,100 people, per capita income 13,000, poverty rate is near 50% in Monolith County. I want to do a little bit of, probably a lot of you know this already, being, in Minnesota a lot longer than I am, but, Minnesota, where we are now is the birthplace of the Dakota Nation. And, it's down near the airport is a sacred site. The airport is a sacred site for the Dakota Nation. The Ojibwe have been present in Minnesota for 1,500 years. And then around the time of the Minnesota Territory, and this isn't unique to Minnesota, this happened all over the country, but I'm featuring because we're in Minnesota, land grabs for tiny amounts of Zebulon Pike of Pike's Peak fame came into town and bought the whole area around Fort Snelling for around $3,000, which, that was, not much considering for the land they got. And then the government didn't even pay the $3,000. They paid interest on it for a little while. And all the indigenous people that lived down there were blocked from their land and starved out. The market value of that land that UMN sits on alone is $543 million. So, if that wasn't enough to break the trust, then there's, boarding schools. If you haven't read the history of boarding schools, I very much recommend it. Research malfeasances, and then this mix and match of like, aren't all Indians the same? Put the Ojibwe and the Dakota together. Many of them on that, White Earth Indian reservation that's up in Monolith County. So, I could have done many different stories of broken trust with various different minority groups. Chose this one to highlight. But, things have consequences. And so the mortality rate among American Indian, Alaska Native persons it's higher. I have some more slides that talk about how much higher. The mortality rate's higher, the incidence rate is higher, and all of this could have been anticipated. The H1N1 influenza epidemic or pandemic in 2009 predicted this. And so, here's my next hero. This is Mary Owen up at the Duluth campus. She has the Center of Excellence for Native and Minority Health, and is also this year happens to be the president of the American Indian Physicians. And so, she has her job. She is plenty busy, and she heard vaccine was coming, and so she got everybody mobilized, nationally to start preparing the community for COVID immunization campaigns. Didn't wait to find out that there was a little bit of, I use the word, a little bit of distrust about the vaccine and the fact that this was coming from the government, and, really did really great grassroots efforts to try to prepare the community for the rollout of the COVID vaccine. So here's where we are now. Hennepin doesn't look like Monolith County because it's a patchwork. In Hennepin County and Ramsey County, you can kind of see over there at the edge, we have both the highest percentiles and the lowest percentiles of social vulnerability with this, this patchwork of inequity. There's many stories of inequity. I could do a whole grand rounds on, the various, health inequities that exist. Again, these were all built. These weren't things that just kind of happened. Redlining, that horribly, in fact, impacted the Black community, and just a number of these. And these all result in, in breaks in trust. And so that when people need to most trust, they are least able to trust. So we have a chance. We have a chance with the vaccine now to get it right. We can roll this out, and we can do it with, I stole the slide from Dr. Nunez, who, talked last week of, the difference between equality and equity. Handing out vaccine, distributing vaccine is not like a poker game. It's not, one for you and one for you and one for you. But to really do it with an equity lens, you need to know, who is most affected, who's most impacted. And, and part of that also, for the healthcare workers, who can we afford least to lose in this? So this is the data. I alluded to the American Indian, Alaska Native, rates. So this is who's most impacted. This is who's getting more COVID. This is who's being hospitalized with more COVID. These are the people who are dying of COVID. So Alaskan Indians, Black, African American, Hispanic, Latino, case rates are around 1.5 to 2 times as much, using white non-Hispanic as the baseline is 1.0. Hospitalization rates are 3.5 to 4 times the amount, and death is 2.5 to 3 times as amount. So, we can use this data now as we're planning to, roll out vaccine. All of you are going to be public health officers deciding, how we're going to roll this vaccine out. So, here's, another sort of picture of this. On the left is the US population, the distribution of the various racial ethnic groups. And on the right is the COVID mortality. So, who is dying disproportionately? Where is the big pieces of the pie, bigger or smaller proportionally? So, again, it mirrors the upper one. So how do people think we did with the vaccine rollout in the first month? So, oh, yeah, guess we didn't achieve our equity goal. The rate of I'll just take the African-American one. The rate of African-Americans are 12.2 in the population. Their mortality was 18.7% in the population. And yet the vaccine delivery is 5.4%, very clearly a mismatch. Even that number 14.4, that's another thing that results from a decision that was made. So 14.4 is unknown. And it's really that the people administering the vaccine didn't ask. They didn't ask what people's ethnicity was or write down what the race was. Lots of different reasons it could be, and I'm not going to speculate, but it was not prioritized that we know, so that we can do this as a CQI project of, are we achieving what we want to achieve? Because we don't even know 14.4%. And I'm not even going to try to hazard a guess of who those 14.4% are. So some of it comes from that the first push really was for healthcare providers. And so this is another place where systemic factors are going to impact it, that you're going to be layering one thing with potential inequity onto something that already we know has inequity. So the workforce, at least of physicians and nurses, is way not in balance with the US population. Again, I'll look at the Black population, that despite 12.2% of the population being African-American, only 5% of the physicians are and 10.4% of the nurses are. So if you prioritize healthcare, and I'm not saying we shouldn't prioritize healthcare, because we need to protect our healthcare workforce. So you're going to layer, one inequity onto another inequity. So this can all get a little overwhelming, because you're like, all right, now I'm supposed to solve COVID. I'm supposed to do vaccines in an equitable place. And now I'm faced with yet another inequity. And the whole thing can get a little bit overwhelming. So I'm going to have my next hero. So my next hero you saw last week, and I will do full disclosure, is also my wife. So she at Drexel, there was a post-bac pipeline program that just wasn't working. It was for URM students. Came into the program, and if they hit a certain benchmark, they automatically got admitted to the medical school. They only had a 40% success rate in that program. She found it unacceptable. The kids that did make it through were ones that then often struggled. And so she took it over. She was assistant dean there, associate dean there, had plenty on her plate. But she rolled up her sleeves, and she worked with every single one of these kids. I'm sorry, kids, young men and women. Showing my age, and got, in the first year of doing it, the rate up from 40% to 85%, and in the second year got it up to 92%. And not only did they make it into medical school, but they thrived in medical school. So again, another stepping outside of your exact job role and getting something done. So this is another picture of back to the vaccine, the Black share of the general population, the vaccinated population. And so, the yellow dot on the right is the, share of the population, and the blue dot on the left is the percentage that has received vaccine. And basically you see from this, the more Black people that are in a state, the worse it is. Not just that, of course, with more Black people, there's more Black people to not immunize, but it just gets proportionally worse. This thing I find particularly sad. So one of the things that came from especially these states in the Deep South was that they said, well, we can't immunize our people over 75 because we don't have any Black people over 75, which I just find so incredibly sad, and such a vivid picture of the health disparities in general in people of color, is that not enough people who are Black in the states of Mississippi, Georgia, Louisiana, Alabama live old enough to be able to get vaccine because they're not there. So how is Minnesota doing? Minnesota's doing okay. I know a lot more about Minnesota because kept pretty close contact with the health department here. But Minnesota, I think has really done it from the right approach. Has an equity group really looking at this, trying to plan for this, anticipate this, and you see, this is the place where being, in the dark blue color is a good thing, because the dark blue color means more people got vaccines. So back to Monolith County, where we had so much vulnerability, we had so much disease, we also have so much vaccine. So that's really good. Minnesota has done proportionally better than a lot of states around our American Indian population. Still a lot of work to do around Black African American, Hispanic, multiracial. So I'm going to do a case study and where things really, really went poorly. So this is how, this is a Hillsdale County in Michigan. So Hillsdale County has Hillsdale College with 800 employees, Hillsdale Hospital with 400 employees. The state is 97% white, 8% poverty, had 3,000 total cases of COVID and 68 deaths by early January. So total doses that were given to the county were 50 doses per 1,000 people, which it's comparable to many other to many other counties. But this then becomes like the poker game. We're going to give this group the same number that we give everybody else. Hillsdale Hospital, though, was given disproportionately control of the vaccine for the county. The county health department was only given 400 doses, and Hillsdale Hospital was given 1,950. Again, something based on a decision is that Hillsdale College had one of the freezers. So, the vaccine went to the people that had the freezers. So Hillsdale Hospital and Hillsdale College became in control of vaccine rather than the health department for the whole county. Compare this to Wayne County. Again, 68 deaths total in Hillsdale County, but 60 deaths a week in Wayne County had a similar number of doses per capita given. So, right away there, you say, is this an equitable distribution of vaccine? So 400 doses were given by the hospital to eligible healthcare workers. That's good. That's who it's targeted to. But then things started to go off the rails a little bit. 200 doses were given by the hospital to educators. Educators, not, I'm picturing school teachers. These were the educators over at Hillsdale College because, again, they had the freezer. So there was this sort of this sense of like, well, they had the freezer, so we gotta sort of take care of them. And then kind of on their own, again, not with guidance from the health department, kind of on their own, they gave out 1,525 doses to daycare workers, bank employees, clergy, grocery clerks, people that are in a much lower priority group. And this is still late January when most places around the country have not even finished giving doses to the healthcare workers. So all they had left at the end to sort of fit into the general pool was 225 doses. And these all went, these were going to go to people over 65, which kind of was the next tier rather than the educators and the people that worked in the bank. And registration closed in 12 minutes because this was the place where the health department got involved. So this, at least to me, is a clearly inequitable distribution of the vaccine. It breaks down a public trust, maybe not a public trust for Hillsdale County, although I suspect it is, but it's certainly for the people in the rest of Michigan and the rest of the country that are struggling to get vaccine while it was inequitably given. So you kind of look at like, why does stuff like this happen? Are the people evil? No, the people probably aren't evil. They are, but it comes from bias, explicit and implicit bias, where you start favoring your own. You start like we have to protect our own over everybody else. Inexperience. You had hospital pharmacists. Well, I love hospital pharmacists, but hospital pharmacists in charge of distribution of vaccine for the whole county, and just this hubris of that one individual institution is going to take responsibility for the whole county. Again, not in a county where there wasn't a health department and there wasn't a very good state health department in Michigan that could have guided how this happened. So this is the kind of, these little decisions are how inequity gets built into America's vaccination system. It's a really good report written by ProPublica. Most places having internet access greatly advantages you. New York allows phone registration only. Florida and California, drive-up sites predominate. Nebraska, no vaccinations for undocumented immigrants. Tell me there's vaccine hesitancy in this group of folks that are standing outside in the cold in Philadelphia waiting for vaccine. And, this is because of this homegrown solution hero. This is Alice Stanford, who's a pediatric surgeon in Philadelphia, who left her practice and started COVID testing and COVID immunization out of the basketball center at Temple University, and had a line of people, and she managed to immunize the same number of people in one day as the rest of Philadelphia had immunized that whole week through the rest of it. Homegrown solutions in places like West Virginia, Alaska, New Mexico, it all brings it down to a community level. So what happens when you have broken trust? People disengage, they become angry, you get all this susceptibility to disinformation is what happens. We know the vaccine works. Deaths among nursing home residents plunged. And yet you still have, survey after survey that say that people just don't trust the vaccine. In this survey, 38% of the people said, I don't trust COVID-19 vaccines. It's, predominant, how does it sort out to? It sorts out to, a Republican versus Democrat thing. Republicans don't want vaccine, Democrats do. There was just another poll that just came out this week that showed the same thing. You start doing the qualitative information from this. I don't trust pharmaceuticals. The nation will achieve herd immunity without me. This is, lack of trust, lack of trust, lack of trust. So how did we get here? Vaccines are, one of the modern wonders of technology. We've had a result of 92% decline in deaths and 92% decline in cases and 99% decline in deaths from vaccine preventable diseases, prior to, the sort of the golden years of vaccine development. Then in the 80s, we started making vaccines that were, not as exciting to people. Very few people knew somebody who died from HIB, never heard of HIB. We gave hepatitis B vaccine to babies, and people are like, babies don't get hepatitis. Varavax was viewed, varicella was viewed as almost a rite of childhood passage. We came up with HPV, that instead of becoming the cancer vaccine, it became the sex vaccine. And then in 1998, Andrew Wakefield wrote an article that was later retracted, linking MMR with autism just at the same time as the internet was really taking off. And then we get to this. Where, the same baby who, was representing, deadly diphtheria, get your immunization 50 years later, is now, representing the greatest lie ever told. There's always been a little bit of vaccine resistance, but it's turbocharged now. We have 1 in 4 parents expressing serious concerns about vaccinating their children. The rates of children at 2 years of age with no vaccines is rising. 1/3 of children are on the recommended schedule. And the amount of disinformation and vaccinations and sources for the dissemination are rising. If you want to read one article on vaccine hesitancy and things to address it, this is a great article. What can we do to overcome vaccine hesitancy? The article goes through all of it. It's about working with people. All of this. It's about building trust, teaching skills, providing support, communicating better. If you want to follow only one person on Twitter, you need to follow Kim Manning. She's at Grady Doc. She does the most incredible descriptions of how she talks to people about vaccines. It's a model of motivational interviewing. She even convinced the guy who came to take a boot off her car to get vaccine, because she just started chatting him up about it. So it's not a surprise to anybody, I think, that we are no longer the trusted experts we once were. I've been doing this a little bit longer than some of you, and I came in when, we were still trusted experts. I watched Marcus Welby growing up. But there's actually a paradigm to describe this. So first of all, there's perception of a void of trusted medical experts, that nobody believes in expertise anymore. Dr. Google is more important than, doctor around the corner. But even more than that, there's this belief that there's a personal truth is more important than evidence. It's not just that we don't have trusted experts, it's more that we don't need experts. And so when you get that, you end up with all these alternative facts thriving. You get information that gets easily manipulated by people that are bad actors and just want to manipulate it, rather than people that have sincere differences of opinion. YouTube removed 30,000 videos with vaccine misinformation just since November. So then that gets us into conspiracy theories. So there's 5 critical elements of a conspiracy theory. There has to be a pattern. This is what can be just random events start looking like a pattern. It has to be that the conspirators are conspiring deliberately. This is planned. They're working together. There's a threat involved. There's always a threat, and there's also it's secret. And you go from just these vague things. So they end up with people that just kind of start out with looking for information, and then maybe a little bit of skepticism, and then they end up actually paranoid. And that's how you get stuff like QAnon, that there's, this cabal of Democrats, working out of a basement, for, child pornography. And it comes together if you look at these conspiracy theories and how they're formed. So who's susceptible to conspiracy? Well, we all are. I'm not sure that there was a lone gunman at, JFK's assassination. But I don't think that that's something that ends up ruling my life. People have non-functional threat management systems. They stop learning, about alliances, who's somebody that I should align with and who's somebody that I shouldn't. They overestimate the power of individuals and institutions. A lot of people have had experience with bad outcomes resulting from unfair treatment. If an event is large scale, there's a high number of people who want to join it, and there's a danger. If you mistake a snake for a stick, that's bad. If you mistake a stick for a snake, that's not bad. And then along came 2020, and all of this was on steroids. And conspiracy theories really make sense of a world that makes no sense. That's why evolutionarily we're so susceptible to them. And trust does not thrive in uncertainty. So breaks with reality, conspiracy theory. People can hold 5 different theories of something that are all conflicting with each other, and they can hold them all to be true at the same time. So COVID-19 is a Chinese germ warfare, and at the same time, it's a hoax. People can hold those 2 opposite views. So none of this has to make sense to us, and I think we have to try to stop trying to make sense of it, because it's all about a person seeking their individual truth. So let's now put masks into the equation. So now we're on this landscape of, everybody is sensitized, everybody is feeling under threat, there's low trust. And so, a mask can be a good thing, or a mask can be the first step in the slippery slope towards total subjugation to the deep state and the military industrial complex. And that can seem really reasonable to you to believe that. So let's just say masks work. But then there's how you talk about masks. So the thing on the left is, that's not something I'd ever show the general public. Some of the general public, even if they understand confidence intervals, they're going to look at those lines and say, well, he didn't even know where the point was. He had to draw those lines of where the point might be. And it's really easy to just draw a line in that if you want to manipulate the facts and show that, that they really don't work that well, or there's only minimal impact. The one on the right, that's the way you talk about it, or you just don't put a graph in. But you can't, also, it's been unavoidable, but you can't keep changing your mind. Masks work, masks don't work. Now you need to do this with them. The thing that we said was great now isn't anymore. You have to be really careful in your messaging. Then we get politicians enter the fray. Kristi Noem, I don't want to just pick on anybody particular, but she's pretty easy to pick on right now. She had a unique approach that made her state better than everybody else. 1 in 500 residents died in South Dakota. The state at one point won the award for having the highest point positivity for the whole country. Their overall positivity is 26.8 compared to Minnesota's 7.4%. 1 in 8 of their residents have contracted COVID, and as with most places, this burden has fallen disproportionately on BIPOC folks. So this is where we are in this country. I think this is political but nonpartisan. There's just everything swirling out there. Like, people feel like there's no such thing as truth anymore. One person's truth is, another person's lie and another person's hoax. So what does that mean for us, importantly? This leads, lack of trust and non-reality based thinking lead to vaccine hesitancy, leads to low engagement in risk reduction strategies, inaccurate history taking. People don't adhere to the regimens that we prescribe because they don't believe us. They don't believe in them. Dr. Google told them something else. Harmful non-science-based remedies. And at a society level, we make poor public policy when we do it not based on scientific evidence. There's violence, horrible, horrible violence yesterday in Atlanta that I don't want to go without note. Racism and the other isms that contribute to adverse childhood experiences, so well outlined in Grand Rounds last month. And what is it that's in our environments that's leading to this? It's a mismatch in demographics between medical staff and patients. We talked about that already. Policies designed to benefit those born on third base thinking they hit a triple. People that have, mobility and cars and insurance and time to take time off to go to a doctor. Differential quality of facilities for the haves and have-nots. I travel all over the country, and I haven't been out of my house because of the pandemic much, but there's a huge difference usually between federally qualified health centers and academic medical centers, many of them lined with marble lobbies. Those situations just smell of power and privilege and make it hard for people to trust that their needs are first. And poor public policy that made by the haves who just directly disproportionately impact the have-nots. Back to Kentucky. This is my last hero. This is Jabari Bruton Barrett, who was the person who was assigned to Kentucky. I think this picture says it all. We were really, really successful there. One of the primary care doctors I talked with there had been a coal miner before he became a family medicine person. And he said, we trust each other here. He says sometimes it feels like all we have is trust, and we trust each other, but we don't usually trust outsiders. Our project there required these folks to do a lot of changes to what they were doing already to fit into the model that we've developed in the South Bronx. And they found a 20% seropositivity for people coming into their emergency room, and they got them linked into care. Because of Jabari's efforts, laws got changed so that women didn't have to go up to Lexington to get care, but got care then, down in Hazard. So what is it that we need to do? So first of all, we need to remember that it's not up to those who need to trust us to be better at trusting us. It's up to us to be more trustworthy. Use your superpowers. Physicians have superpowers. Build a pipeline, plug a leaky pipeline. We need to always show that we're working for them. It can't be taken for granted. Change what's not working. If everybody on this call, everybody in this Grand Rounds today, change just one policy that doesn't make sense, change just one thing that wasn't working for patients in your clinic, think of the impact that would have. Advocate for concrete change in public policy. Dr. Neglia sent us a request yesterday of somebody who wants some advocacy in our effect. Do it, but and don't be afraid to volunteer to go testify in front of a legislative group. Explain things that are true in a way that sounds true. We get so up into our heads of, p-values and shades of gray that, we take something that's really, really straightforward and we make it sound really complicated. Battle conspiracy communities with communities of truth. And listen more than you speak. We need this. I didn't talk about the trust that we need to have of our patients. I think that trust has been violated and needs to be said. We had hoped that they would do the basic things that would protect us and protect themselves, like wearing a mask and now getting a vaccine. And we're not feeling so trusting of the public right now. And I think we need to talk about that. We need to talk about the ways that we're not feeling so trusting of the institutions that we work in, and think of the ways that the institutions may not feel that we're trustworthy now, and need to have a dialogue on this. So this is my acknowledgement to, these are the people, the shoulders that I stand on. These are the folks at Dorothy Mann Center at St. Christopher's. This was the team. This was on one of our retreats, and these were my comrades in arms at Focus as we traveled around the country and divided up the country for the various places that we did. And so I will stop now. Hopefully there's enough time left for some questions. And I'll open it up to questions and put it back to Emily.
Great, thank you very much. We, for our attendees, you can feel free to put questions in the chat or in the Q&A section. Our first question comes from Amyessler. What's your response to those who argue that we should open the floodgates and make vaccine available to everyone without the complicated steps of equitable distribution because, they argue, this will get us to herd immunity the fastest, and getting us to herd immunity ultimately is the best for everyone? Thanks, great talk.
I think herd immunity is best for everyone, but herd immunity is not necessarily, herd immunity doesn't just happen as a point of inflection. Herd immunity gradually gets there. And I think you need to think about your herd. Not all the herd, we've got goats and we've got cows and we've got sheep, and, people have differential risk. And I think what we need to do in this is really look at who are the people who are most vulnerable, who are the people that are most impacted by this, and make sure that there is distribution to them first. So I will open the floodgates in those places. So the picture I showed in Philly of people standing in line and Alice Stanford's great efforts, she talked the folks in Philly who had a disastrous rollout. She talked them into not having it just be by the childcare workers and the categories, but she opened it up by zip code. She said, these are the zip codes that are most affected. And she had a mass vaccination event that then anybody in those zip codes could come and get vaccine. So I think that this is something, I really appreciate how Minnesota has done restrictions, and how the governor talks about, turning the dial up and turning the dial down in certain areas. And I think we need to do that regionally based on the zip codes that are most impacted. And we need to do it by looking at, in aggregate, who has been most affected by this.
I just wanted to underscore that there are little herds within herds, and we've seen that illustrated so clearly for us in our community with the measles outbreak that did not affect all children. It affected certain subsets of our population. So I think that's really important for us to keep in mind as we're planning vaccine. Dr. Naglia says, how do we encourage and facilitate trust when groups that are spreading misinformation seem to be more organized and better resourced? What can we do day to day?
That's a great question. So the big picture of that is we have to be more trustworthy in general, sort of all those things I talked about. We have to show that we're welcoming. We have to establish ourselves as an authority figure, or an authoritative figure on knowing what we know. So we start, I view it, we start first with the patients that do trust us. My impression is that this is a really good pediatrics department, and I'm actually really looking forward to getting to know people better. But, take the places where people trust us already and then expand beyond that. Use the folks that trust us as, trusted ambassadors. Look for people, the department, especially over at Kook, it seems like have really established really good relationships with community people already. Tap them, use them, have them be the people who will testify for us. Of that, those folks over there. That's one of the things that Dr. Owen did with the Indian tribes is, talk to the elders, talk to the people up there that people already trust, and get them to be your ambassadors. Because it's not so simple to just say, hey, trust me. You have to be trustworthy. And, I think we're in a good position and that we have been trustworthy to people. And we build on that trust to very specifically and intentionally build more trust.
Great, thank you. This one comes from your own division, Dr. Shane McAllister. Can you comment on the specific role our trainees can play in trust building? I feel like the younger generations are at baseline more sensitive to these issues.
No, I think that that is true. I really, when I talk about the trust ecosystem, I really mean, listen to the other people, trust it. We have to be like the coal miners who trust each other. The coal miner doctor said, when we were down in the mines, we knew that, it was everybody else that was around you who were the people that, were whether you lived or not coming out of the mines. And I think the pandemic has kind of brought that for us. You have to depend on all the people around you. And I mean, all of the people, I trained back in the days of hierarchy of, oh my God, would you dare question an attending? You just, you put up with it. I was horribly abused on my surgery rotation by one of the residents who, made obscene phone calls, to my house. And I didn't dare report it. So I think that we are in a new era, which I will admit I was reluctant to embrace the wisdom of the millennial generation that have learned that a lot of them really do get it more than we do, and to listen and put them in positions of put them out front and listen to their suggestions. I don't know if that answered the question.
Yeah, I think that's, thank you very much. It seems like you've been thinking a lot about trust, and that's certainly something I treat it as a precious gift that a patient and their family can give to me. And I think as we think about our own well-being and resilience, that's a magical moment when a parent says, I trust you. I wanted to hear what you thought. And I, as a primary care provider, I can build that over multiple episodes of care and, multiple small acts for that child or another sibling. But could you comment on the challenges of building trust in another setting, especially in a hospital setting where we may be coming and going and our touch points are shorter? What are some strategies for building trust in that setting?
I think one of the important things is to not take it personally. I am of course, incredibly thrilled when someone says they trust me. I also view it as a conditional trust. I'm thinking back to a patient that I took care of a long time ago, of a baby that was newly diagnosed with HIV. And the parents came in, they were shocked, they were horrified. It was, it was a problem with the system. The mom had not been tested. And she said to me, she goes, they drew all that blood. Why didn't they draw an HIV test? I would have done what I need to do. I would have taken medicines. And, so they already came in not trusting us, that already the system had failed them. And the father said right up front, tell me my daughter is going to get the same medications that Magic Johnson's getting. And I said, squirrel running behind you. I said, she is. In fact, she's going to get the exact same drugs that Magic Johnson's getting. And then I looked at him and I said, I know you don't believe me now. But that's okay, because you will come to see as she gets better and does well, but you're not going to believe me today, and that's okay. So I think it's okay to acknowledge to people that it's okay that they don't trust us, and that that's something that we need to build. And when it's working, and when it's not. And I think you need to put it on the table that it's okay that they don't trust you, because then that's just another place of distrust. I think the other thing with that is also don't take a no as a no. A lot of vaccine hesitancy it's just hesitancy. It's not a hard no. I mean, there are hard no's, but it's just I don't want it today. I don't trust you today. I don't have enough knowledge today. Or even sometimes it's again, go back to Kim Manning. Kim Manning's Twitter stream is just incredible. She describes this whole thing. She was at a mass vaccination event, and an older Black woman came in to get vaccine and was clearly uncomfortable getting the vaccine. So she could have just given the vaccine and the woman would have gone home really, really uncomfortable. But instead she talked to the woman and said, you seem uncomfortable with this. Are you sure you want this vaccine today? You know, and it might have had the impact of the woman walking away and, you know, having a low vaccination rate. And the woman says, yes, my daughter says I should get it and my son says I shouldn't. And I think my daughter just wants me to get it so that I'll take care of her kids. And because I'm vaccinated. And so Kim worked through this incredible discussion with the woman, and the woman at the end of it said, okay, I'm ready now. You know, so it's, you know, it's not pushing it. It's not pushing it. It's not taking a no as a permanent no. It's asking the question of, well, what is making you hesitant? You know, and it's hard to do this. It's, you know, we're all tired. We're all frustrated. And we're probably more tired and more frustrated than, you know, we've ever been because of the pandemic, and especially tired and frustrated with a public that all we see out there is people going on with their normal lives while ours have been wrecked. And so it's now we have to use our superpowers to get over that or push through that at least, and be able to have the empathy and compassion that even when you want to wring their necks, because you sometimes are going to want to, even when you want to wring their necks, take a patience moment and find and explore what's going on.
Have a famous story involving, are you going to trust me or Jenny McCarthy, that I tell to my continuity residents that I will not get into today. There's a question from the audience about just thinking more broadly about the team that builds trust. So how can we sort of train and really involve the other members of the interprofessional team, nurses and hospital staff, on building trust? They often have the most patient contact, so they can really work to support trust, or sometimes may inadvertently decrease trust.
Yeah. Yeah, I mean, you know, I showed those pictures of the group of folks that I work with. Very few of them were doctors. I was the only doctor in the focus group. And, you know, I've learned the most about patient care, I think, from the social workers I've worked with and from the peer counselors. In our HIV clinic, we had a woman who was positive herself and had a baby who was positive, who on my toughest cases, I always took her in the room with me. And, you know, I would go through all this stuff and I would feel like I was doing such a good job. Some kid who wasn't taking his meds. And then we'd go out of the room and she'd look at me and she'd say, you know, Dr. Foster, he's not going to do a thing you said. And so, all right, what do I need to do differently? And then I'd go back in with her and we'd do it differently. So we need to learn from them. And then for the ones that seem to be in the way, because there's always those two, the ones that seem to be in the way, find out why they're in the way. You know, maybe they're a contrarian and they're just a pain in the neck, and maybe they need to get performanced out because maybe this isn't the right place for them. But the majority of them aren't that. The majority of them are people that they've got their trust issues too, and that they feel more aligned with the patients and have taken on this role of protecting the patients from you. And so that's especially someone you got to work on a trust relationship with, because once you have an alliance with them, they're going to be your best friend.
Yeah, I think that's a really great. It's just the, you know, I think investment of time and relationship in all aspects with our team members and with our patients and families. Someone, thank you, Emerson, who put Grady Doctor Twitter handle in the chat. We'll see if I think we are just about at time here, but thank you so much. That was just an excellent review of work we have to do here in Minnesota and some of the objective measures we can do to help target our efforts to better build trust and provide equitable care to our patients. And hope everybody has a wonderful snowy Wednesday, complete with, you know, maybe some wildlife sightings and other things. So thank you so much for a great talk, and see you all at faculty meeting later today.
Thank you
for the invitation.
Thank you, Jill.
Bye.
Bye.